Hi, welcome to our 10th video in the Rapid Interpretation of ECG series. In this video, we will explore bundle branch blocks, how to differentiate between right and left bundle branch blocks, and how they can affect or mimic the ECG patterns of conditions like complete atrioventricular block, intermittent Mobitz, or ventricular hypertrophy. Finally, we will wrap up with a conclusion. A bundle branch block occurs when there is a delay or obstruction along the pathway that electrical impulses travel to make the heart beat. This blockage can happen in either the right or left bundle branch, leading to delayed depolarization of the corresponding ventricle. As a result, the two QRS complexes, which represent the depolarization of each ventricle, overlap and create a single, widened QRS complex on the ECG. To diagnose a bundle branch block, we look at certain criteria. If the QRS complex duration is greater than 120 milliseconds, or 3 small boxes, it indicates a delay in electrical conduction. Another important finding is the presence of a second R wave, known as R', which suggests delayed depolarization of the affected ventricle. Additionally, the RS wave pattern provides valuable insights into how the ventricles are depolarizing and helps distinguish between a right and a left bundle branch block. Differentiating between a right and a left bundle branch block is crucial for accurate diagnosis. In a right bundle branch block, specific changes appear on the ECG. In leads V1 through V3, an RS-R' pattern is often seen, which is described as M-shaped. In the lateral leads, which include lead 1, lead AVL, lead V5, and lead V6, a wide, slurred S wave can be observed. A useful mnemonic to remember this pattern is MaRRoW. In a right bundle branch block, the QRS complex in lead V1 resembles an M, while in lead V6, it looks like a W. On the other hand, in a left bundle branch block, the ECG shows different characteristics. In leads V5, V6, lead 1, and lead AVL, broad, notched R waves are seen. Meanwhile, in leads V1 and V2, deep and broad S waves are present. To help remember this, the mnemonic William is used. In a left bundle branch block, the QRS complex in lead V1 looks like a W, while in lead V6, it takes on an M shape. In some cases, a patient with a bundle branch block may experience episodes of supraventricular tachycardia, which can result in widened QRS complexes. This can make the ECG appear similar to ventricular tachycardia. Since the treatment strategies for these conditions are different, distinguishing between them is essential. One way to differentiate is by analyzing the heart rate. Ventricular tachycardia often occurs at rates between 150 and 250 beats per minute, whereas supraventricular tachycardia with a bundle branch block typically falls at the higher end of this range. Careful examination of the QRS morphology in all leads can also provide valuable clues, though this requires expertise and a detailed understanding of ECG interpretation. Additionally, considering the patient's clinical history, any structural heart disease, and the circumstances under which the rhythm started can help in making the correct diagnosis. Intermittent bundle branch blocks can sometimes progress to higher degrees of atrioventricular block. In a complete atrioventricular block, also known as third-degree atrioventricular block, both bundle branches are blocked, preventing any atrial impulses from reaching the ventricles. This results in P waves that do not have corresponding QRS complexes. Another condition to watch for is Mobitz type 2 second-degree atrioventricular block. This is characterized by intermittent non-conducted P waves, but without the progressive prolongation of the PR interval. When this occurs alongside an intermittent bundle branch block, it serves as a warning sign that the condition may progress to a complete atrioventricular block. Diagnosing ventricular hypertrophy in the presence of a bundle branch block presents another challenge because the altered QRS morphology can interfere with standard diagnostic criteria. In a right bundle branch block, the usual criteria for right ventricular hypertrophy may still apply, but careful analysis is required. However, in a left bundle branch block, traditional voltage criteria for diagnosing left ventricular hypertrophy become less reliable. In such cases, alternative diagnostic criteria or imaging techniques may be necessary to accurately assess the presence of left ventricular hypertrophy. In conclusion, accurately diagnosing bundle branch blocks requires a detailed analysis of ECG patterns, focusing on QRS duration, the presence of a second R wave, and specific RS wave patterns. It is important to differentiate between right and left bundle branch blocks, as well as to recognize situations where supraventricular tachycardia with a bundle branch block may mimic ventricular tachycardia. Being aware of the potential progression to higher degrees of atrioventricular block and understanding the challenges of diagnosing ventricular hypertrophy in the presence of a bundle branch block are key to effective patient management.